Okay, so here's a diagram of the anterior cruciate ligament, and you're looking at the right knee from the anterior aspect. So this would be the medial knee here, this would be the lateral knee here. So the anterior cruciate ligament has its femoral attachment, its proximal attachment, its origin is laterally. It's on the lateral wall of the inner aspect of the lateral femoral condyle. This area is known as the intercondylar notch. So the intercondylar notch is between the condyles. That's what intracondylar means. So here's the lateral femoral condyle. Here's the medial femoral condyle. This is the intracondylar notch here. And the anterior cruciate ligament attaches up here on the lateral aspect of the intracondylar notch. So its origin is lateral. And then it comes and it crosses, and that's what the cruciate ligaments mean. They're crossing ligaments. And it attaches anteromedially here, which is on the anterior part of the tibial plateau near the tibial spine, or I should say the tibial spine. You can see the anterior tibial spine here, and the posterior tibial spine is tucked away back in here. So the anterior cruciate ligament begins laterally and progresses anteriorly to attach anteromedially on the anterior aspect of the tibial plateau. And the anterior cruciate ligament is a fascinating ligament. It has kind of a coiled or a twisted cable type of structure, such that it becomes separated out into an anteromedial band. So here we see some of these anterofibers tucking and coursing and getting rotated and then attaching over here medially. It's the anteromedial band. And then the posterolateral fibers attach over here laterally on the anterolateral aspect of the tibial plateau. And this is a dynamic ligament where the anteromedial band tightens when the knee approaches full flexion, and the posterolateral band tightens as the knee approaches full extension. So the anteromedial band would resist hyperflexion forces, posterolateral band would resist hyperextension forces, and this allows the ligament to function and be active and provide passive restraint throughout the full range of knee joint flexion and extension. And according to some research studies, the anterior cruciate ligament has proprioceptive nerve endings. So it's a dynamic structure that contributes to the neurologic stability and the neurologic stabilization of the knee joint itself. So thus, you can see that injury to the anterior cruciate ligament would result in loss of functional as well as loss of anatomic stability. There would be a loss of anatomic stability and a loss of functional stability through diminished neuromuscular control of the knee. The anterior cruciate ligament is the primary restraint to anterior translation of the tibia here on the femur here. So the ACL here prevents forward movement of this tibia relative to the femur. And of course, the posterior cruciate ligament is going to do the exact opposite. The anterior cruciate ligament is also the primary restraint to knee hyperextension due to the action of the posterolateral band. Now, when the knee is in full extension, the anterior cruciate ligament provides restraint both to varus and valgus angulation. And that's interesting because the anterior cruciate ligament can be injured by both valgus and varus forces, especially when the knee is planted and in full extension. Okay, and so that would likely involve injury, most likely, to the posterolateral band. And then, in addition to resisting anterior translation and varus and valgus forces, the anterior cruciate ligament is a restraint to both internal and external rotation when the knee is at full extension. And in opening today's discussion, we talked about the osseous restraints provided for by the shape of the structures. And because of the flat and planar surfaces of the tibial plateau, we don't have a lot of osseous restraint to rotational forces. So we simply have here the anterior cruciate ligament located centrally, which can resist internal and external rotation forces. But because this ligament is located centrally versus peripherally here, it has a small moment arm and a small point of leverage, such that it's easily overwhelmed by both internal and external rotation forces, and is easily injured and damaged by internal and external rotation forces. So when we do our assessments of the anterior cruciate ligament, we want to include internal and external rotation positions in our physical examination testing of this ligament. Okay, on physical examination, the most specific test for anterior cruciate ligament that's described in the literature is the Lachman test. And with the Lachman test, you place the knee in 20 to 30 degrees of flexion, and this femur is stabilized anteriorly. So the doctor's superior hand is placed on the anterior aspect of the distal femur just above the patella and applies a posteriorly directed stabilization to the femur. Then with the opposite hand, the examiner applies an anterior force to the proximal tibia to attempt to translate the tibia anteriorly on the stabilized femur. And the displacement is assessed. So any significant displacement above and beyond normal ligamentous play would qualify for ligamentous laxity. With the pivot shift test, this is an interesting test. In early flexion of the knee, when an internal rotation and valgus stress is applied to the knee, the anterolateral quadrant of the tibia will sublux posteriorly. This subluxation is reduced by the posterior pull of the iliotibial tract as the knee continues its flexion up to 20 and even as high as 40 degrees. So this test is completed all in one maneuver of taking the knee from full extension all the way through to approximately 40 degrees of flexion, at which point you will feel a palpable clunk over the anterolateral quadrant of the tibia as the tibia first subluxes itself and then reduces itself throughout that range of motion. So a palpable clunking qualifies as a positive pivot shift test and is suggestive again of laxity of the anterior cruciate ligament. Now on radiographs, many times with injury to the anterior cruciate ligament, the plain films will show an avulsion fracture of the insertion of the anterior cruciate ligament onto the anterior tibial plateau. Sometimes you will see an avulsion fracture of the anterior and posterior tibial spines. And then also you'll see occasionally a Sagond fracture. And a Sagond fracture is indicative of a varus stress to the knee because it involves a lateral capsular avulsion from the margin of the lateral tibial plateau. So this is in response to a strong varus stress, strong unrestrained varus stress. Okay, so here we have an AP radiograph of the knee, and this appears to be the intracondylar tunnel view. But anyway, here we see a Sagan fracture, which is an avulsion fracture of the margin of the lateral tibial plateau here. So this is in response to a strong varus angulation in this direction that causes failure of the anterior cruciate ligament here, and then continued opening laterally such that there's a avulsion fracture of the capsular attachment over here on the lateral tibial plateau. So in your knee radiographs, we now have at least two findings. One is the Pellegrini Stieta lesion, and the second here is the Sagan fracture. That would be indicative that your examinee has suffered bona fide injury to these ligamentous structures, and that they may indeed qualify for either an isolated permanent impairment rating or a permanent impairment rating due to combined injury to collateral and cruciate ligament injury. Okay? And I have some statistics regarding patients who have suffered injury to the anterior cruciate ligament, and we're talking about grade 3 rupture injury. And this is a study that I was able to find. It's not a new study. It's a 1994 study, but it was published in a respectable journal, the American Journal of Sports Medicine, and they followed 292 patients, each of whom had suffered a ruptured anterior cruciate ligament. And they followed these patients for an average of 5 years. Well, a small percentage, approximately 20%, underwent anterior cruciate ligament reconstruction within the first 3 months, and another 20% requested surgery over the next 5 years. And the reason they requested surgery was because of adverse impact of this condition on their activities of daily living, particularly adverse impact on their ability to return to sporting activities. Well, the remarkable finding from this study is that 62% were able to function satisfactorily without an intact anterior cruciate ligament. And this may come as a surprise to you that more than half of the patients in this study were able to resume their normal sporting and daily living activities without the passive restraint provided for by an intact anterior cruciate ligament. And this is not such a surprise to me because I myself suffered a ruptured anterior cruciate ligament at approximately age 17, more than 40 years ago, and it was never reconstructed. It was simply resected and cleaned out and debrided, and I was left without an anterior cruciate ligament, and I was able to go on and play all types of sporting activities, including ice hockey and downhill skiing and all kinds of sports that involve cutting and twisting and turning and changes of direction. And that was because, and the reason these patients did so well is because the dynamic structures, the muscles that cross the joint, are able to compensate for the passive restraint provided for by the anterior cruciate ligament. So if you think about it, the primary function of the anterior cruciate ligament is to resist anterior translation of the tibia on the femur. And in the absence of an intact anterior cruciate ligament, the role of restraining the tibia is relegated to the hamstring tendons. So the hamstring muscles and hamstring tendons can satisfactorily substitute for examinees who have ruptured and who have not even had a repair of the cruciate ligament. But the AMA guides tells us that in examinees who have had injury to the anterior cruciate ligament and who have persisting laxity and instability and adverse impact on their activities of daily living, they provide for permanent impairment rating due to isolated cruciate ligament injury and also for combined cruciate ligament injury when the injury to the cruciate ligament is combined with an associated injury to one or more of the collateral ligament injuries. So always assess all of the cruciate ligaments and all of the collateral ligaments to provide your examinee with the most accurate permanent impairment rating. Okay?